Good morning. You are welcome back to the update on management of common NCDs. I'm Dr. Suranga Manilgama, a specialist in internal medicine. I work in Colombo North Teaching Hospital. I will talk on management of diabetes. As you all know, it is a vast topic, so I will concentrate more on type 2 diabetes management, and I will take you through a case scenario, the common case scenario which we get in the common practice, usual practice. A 55-year-old woman, previously healthy, presents with feeling tiredness for 2 weeks. On clinical examination, she had slightly high blood pressure. Rest of the examination was unremarkable. Her capillary blood sugar level was 210. What are your thoughts? Do you think that she has got diabetes? Yeah. So let's see what diabetes is all about. Diabetes is a metabolic disorder characterized by chronic hyperglycemia. It leads to microvascular damage and dysfunction, accelerated atherosclerosis even at an earlier age, and acute metabolic derangements. So let's see what are the symptoms of diabetes. Polyuria, polydipsia, we call them osmotic symptoms. They present with increased appetite and craving for food, and unintentional weight loss, tiredness as in our patient, and recurrent infections, skin and urinary tract, and they also complain of slow healing of cuts and bruises. So let's move on to classification of diabetes. Other than type 1 and type 2, there are a lot more types of diabetes. Hybrid forms of diabetes, hyperglycemia first detected during the pregnancy, and specific types like monogenic diabetes, endocrinopathies, infections, drug-induced diabetes, disorders due to exocrine pancreas, and other non-classified. As you all know, type 1 diabetes is due to absolute insulin deficiency as a result of beta cell destruction. Type 2 diabetes is due to insulin resistance and inability of the pancreas to overcome the resistance. What are the tests to diagnose diabetes? Fasting plasma glucose, random plasma glucose, 2-hour value of OGTT, and HbA1c. So what are the diagnostic cutoff criteria for diagnosis of diabetes? Fasting plasma glucose more than 126 milligrams per deciliter, 2-hour OGTT value more than 200 milligrams per deciliter, HbA1c more than 6.5%, and in a patient with classic symptoms, random plasma glucose of more than 200 milligrams per deciliter. And you have to make sure your lab is using NGSP certified and standardized method when checking HbA1c. Yeah. What is pre-diabetes? Is when fasting plasma glucose between 100 to 125, OGTT value, 2-hour OGTT value between 140 to 199 milligrams per deciliter, and when HbA1c is between 5.7 to 6.4%. Picking up a pre-diabetic patient is very important. Why? Introducing lifestyle modifications will prevent them from progression to type 2 diabetes. Yeah, we know what are the cutoff values for diabetes, and we know what are the tests. Now, let's see how do you confirm the diagnosis. In the presence of classic symptoms of hyperglycemia, or if patient has got hyperglycemic crisis, the presence of one abnormal result will confirm the diagnosis. Example, if patient has got one random plasma glucose more than 200 milligram, that will confirm the diagnosis. In the absence of classic symptoms, you need 2 abnormal tests to confirm the diagnosis. It can be 2 abnormal tests from same sample, such as elevated fasting blood sugar or HbA1c. If you see a patient with an abnormal test result, you repeat the same test or a different test on a different day, as shown in the diagram. If there are 2 test reports, one is normal and the other one is abnormal, what would you do? You repeat the abnormal test for confirmation in few days' time. And if it's abnormal, then you can confirm the diagnosis. So in a nutshell, this is how you confirm the diagnosis. Let's look at the pathophysiology of type 2 diabetes. It is complex and there are multiple distinct abnormalities involved. The hyperglycemia is mainly due to reduced peripheral glucose uptake and augmented hepatic glucose production. And there are many other mechanisms suggested, such as adipocyte insulin resistance and inflammation. And in the pancreas, beta cell dysfunction causes reduced pancreatic insulin secretion and increased glucagon secretion by pancreatic alpha cells. So incretins are hormones produced by GI tract, like GLP, GIP. Those are important in glucose metabolism. So reduced secretion or reduced response to GI incretin hormones have been recognized as an important feature in pathogenesis of diabetes, type 2 diabetes. And there's a hypothesis that hypothalamic insulin resistance will also contribute towards hyperglycemia. And you all know the excess glucose is filtered by kidneys. But in type 2 diabetes, there is increased reabsorption of filtered glucose at the tubules, contributing to maintain the hyperglycemia. So coming back to our patient, considering the psychosocial history, she's a widow and her son has passed away about 3 months back, and she does not have permanent income or good family support. Repeat blood pressure measurements confirmed that she is having slightly high blood pressure, mild hypertension, and she's obese, and she also has got dyslipidemia. And on further examination, found that she is in post-traumatic stress, and currently she is not aware of the implications of diabetes on her life. So these all factors are important in managing the patient. So let's move into the treatment of type 2 diabetes. We need a patient-centered multidisciplinary approach which caters to individual circumstances and concerns, and also availability of resources. Finally, come to your clinical judgment. So what are the management goals for type 2 diabetes? To prevent morbidity and complications, improve quality of life, and improve the survival. Yeah, this is taken from ADA guideline 2021. So patient-centered management of type 2 diabetes describes as a decision cycle. It starts with assess key patient characteristics, consider specific factors that impact choice of treatment, moving on to creating, agreeing, and implementing a management plan, and reviewing, revising, and changing the management plan accordingly. Let's discuss each step. When evaluating a patient, look at their clinical characteristics like age, weight, BMI, presence of cardiovascular risk factors, and presence of comorbidities like established cardiovascular disease, CKD, and heart failure. And also look into their current lifestyle and whether and analyze their psychological state, whether they are motivated to do changes, whether they are depressed due to illness, so on. And also the current cultural and socio-economic context is very important when you are managing a patient with diabetes. Choice of treatment also depends on the specific factors. In our setup, the access, cost, and availability of medication is very important. And then you check the complexity of regime. When you are introducing drugs, the frequency of administration and the mode of administration, like when you are giving insulin. And again, you need to think about the weight of the patient and side effect profile of the medication and risk for hypoglycemia. And you need to think of individualized HbA1c targets, and you choose regime to optimize the adherence to the treatment. During the interview, you need to convince the patient. We need to understand that diabetes is not a painful condition. Patient cannot see the disease, but you see the complications of disease when it occurs. Therefore, it is difficult to convince someone take lifelong medication. Patients should take part in decision-making process. And what do you mean by empowering the patient? Make them feel that disease can be controlled by themselves. Should know the implication of lifestyle, names of the medication, the doses of the medication, so on. And when they are on treatment, always monitor for patients' well-being, medication tolerability, and monitor for glycemic targets, and review and do changes accordingly. And you have to make sure that mutual understanding is there when you do the changes, and make sure the changes are implemented on time. Yeah. Let's see what are the therapeutic options available to treat type 2 diabetes. There are oral hypoglycemic drugs like biguanides, metformin, sulfonylureas, like glycoside, glimepiride, thiazolidinediones, pioglitazone, DPP-4 inhibitors like sitagliptin, linagliptin, SGLT2 inhibitors, empagliflozin, dapagliflozin, alpha-glucosidase inhibitors like acarbose, and some injectables, GLP-1, receptor agonist, and insulin. So coming back to the previous pathophysiology diabetes, I will show you where these agents are acting on the pathophysiological process. The metformin, the primary action is on the liver. Glitazone's main action is on peripheral glucose uptake and on adipose tissues. And insulin and sulfonylureas at the pancreas level, and GLP-1 receptor agonist and DPP-4 inhibitors act on incretin, and alpha-glucosidase inhibitors will reduce glucose absorption, and SGLT2 inhibitors will reduce glucose reabsorption. Yeah. So I will briefly compare these medications and the important characteristics of those medications. Sulfonylureas and insulin cause hypoglycemia, while others do not. And GLP-1 receptor agonist and SGLT2 inhibitors cause weight loss, while glitazones, sulfonylureas, and insulin will cause weight gain. SGLT2 inhibitors and GLP receptor agonists show benefit in cardiovascular and benefit against diabetic kidney disease progression. And SGLT2 inhibitors has a significant benefit in heart failure. The glitazones have increased risk of heart failure, and the metformin and glitazones has got potential benefit towards cardiovascular disease. Yeah, the metformin and GLP-1 receptor agonist both have GI side effects like nausea, vomiting, diarrhea, and in long term of metformin use can cause B12 deficiency. Dose consideration is important in CKD patients with chronic kidney disease. If GFR is less than 45, then you have to halve the dose of metformin. When it is less than 30, usually it is recommended to stop metformin. And SGLT2 inhibitors have high risk of diabetic ketoacidosis, genitourinary tract infections, and volume depletion. And pioglitazone has potential benefit against cardiovascular disease and non-alcoholic fatty liver disease. While as a class effect, it has a high risk of heart failure due to fluid overload, and it is contraindicated in CCF, heart failure. And some of the drugs you don't need to do renal adjustments. For some of the drugs you need to do renal adjustment. I have mentioned already about the metformin. Yes. I will discuss the importance of initial therapy, importance of metformin in great detail. So metformin is the preferred initial pharmacological agent in combination with other lifestyle modifications. The metformin, why I have selected metformin? It is effective and it is safe and it is inexpensive, and it may reduce risk of CV events and death. And once initiated, you should be continued metformin as long as it is tolerated and till it is contraindicated. And there are immediate release forms available. You can give it twice a day, and extended release forms, you can give it once a day. And the principal side effects are GI intolerance, bloating, discomfort, diarrhea, and you can mitigate those by gradual dose titration when you are starting metformin. And metformin is cleared by renal filtration, therefore dose titration is needed in chronic kidney disease. I have discussed already. And very high circulating levels, as in overdose or in the setup of acute kidney injury, are associated with lactic acidosis. And long-term use can be associated with B12 deficiency and worsening of symptoms of neuropathy. So let's see. Usually we start with metformin, but is there a place for insulin at the outset? Yes. Insulin should be combined with metformin at the outset if there is symptomatic severe hyperglycemia, when blood glucose level more than 300 milligrams per deciliter or HbA1c more than 10%. And in a patient, if they have symptoms of catabolic features like weight loss, ketosis, then you need to start insulin with metformin or any other agent. What is combination therapy? The combination therapy is needed with the progression of the disease. So, if patient is on metformin and HbA1c target is not achieved after 3 months of treatment, then you are supposed to start the second agent. And stepwise addition of the medication to metformin is important to maintain HbA1c target. And the treatment up titration should not be delayed, and you have to intensify treatment accordingly. So what are the medications that can be combined with metformin? All those types of medications: sulfonylureas, glitazones, DPP4 inhibitors, SGLT2 inhibitors, CABOs, GLP-1 receptor agonist, and insulin can be combined with metformin. The choice of medication you are going to add to metformin is based on clinical characteristics of the patient and also their preference. So what are the clinical characteristics you are going to consider? The presence of cardiovascular disease, presence of high risk of cardiovascular disease, presence of heart failure, chronic kidney disease, other comorbidities like morbid obesity, and the risk of side effects like hypoglycemia, safety, tolerability, and in our setup, the cost. Yeah, this chart is copied from ADA 2021 guidelines, and this is complicated. I will discuss each arm separately. So these are the cardiovascular outcome trials showing benefit of SGLT2 inhibitors and GLP-1 receptor agonists on patients with cardiovascular risk factors and established cardiovascular disease. Yeah. So now we'll move on to one by one. If patient has got established cardiovascular disease, or if they have got any risk factors of cardiovascular disease, the preferred treatment are GLP-1 receptor agonists or SGLT2 inhibitors, if those drugs are freely available. And if HbA1c targets are not achieved with those drugs, then you can add glitazones, DPP-4 inhibitors, insulin, or sulfonylurea. And most importantly, when cost availability is a concern, the preferable drugs are sitagliptin, gliclazide, moderate release, and the alternatives are acarbose, other sulfonylureas, glitazones, and basal insulins. In the presence of heart failure, again, drug of choice is SGLT2 inhibitors if that is present. And when cost and unavailability is a concern, preferable drugs are DPP-4 inhibitors like sitagliptin. Alternatives are acarbose, sulfonylureas, insulin. And you need to avoid glitazones because there's a high risk of heart failure with glitazones. In the presence of chronic kidney disease or in the presence of diabetic kidney disease or albuminuria, again, preferred choices are SGLT2 inhibitors and GLP-1 receptor agonists, but those are very expensive. In our setup, you can replace with non-renally excreted DPP-4 inhibitors like linagliptin, or alternatives are acarbose, sulfonylurea, insulin, and glitazones. But you may have to use low doses and avoid glitazones in the presence of fluid overload. When there are no risk factors, cardiovascular risk factors, or when there is no established cardiovascular disease, then these points you need to consider. You need to minimize hypoglycemia, you need to minimize weight gain, and you need, especially you need to consider the resource, availability of the resource in a resource poor setting. Yes. If your main concern is to prevent hypoglycemia, then drug of choices are sitagliptin, DPP-4 inhibitors like sitagliptin, GLP-1 receptor agonists, SGLT2 inhibitors, and glitazones. And your main concern is to minimize weight gain, then drug of choices are in the resource full setting, SGLT1 receptor agonist and SGLT2 inhibitors. And if it is not available, then sitagliptins and other acarbose. But remember that sulfonylureas, insulin, and glitazones will increase weight gain. In resource poor setting, like in Sri Lanka at this economic crisis, we may have to use drugs which are available with us. Sulfonylureas like gliclazide and glitazones like pioglitazones and acarbose, and insulin which are available in the hospital setup. Or if patient can afford, you can go for other treatment options. Yeah, let's move on to insulin therapy. Insulin has greater potency in reducing plasma glucose. And when you're starting insulin, you need to explain to the patient the progressive nature of the type 2 diabetes.
Recording in progress. Recording in
each meal. We
progress.
call it basal bolus regime. And if it is complex and patient cannot have multiple doses, you can convert it to pre-mixed or self-mixed insulin. Yeah, let's move on to the glycemic targets. The previous speakers already have spoken about the targets of blood pressure and targets of lipids, so on. So initially I will concentrate on glycemic targets. HbA1c target is usually it is less than 7. Preprandial capillary plasma glucose between 110 to 180. Peak postprandial capillary blood glucose level between 110 to 180. Why I have put a range? Because the goal should be individualized always, and it depends on the duration of disease, age of the patient, life expectancy, presence of comorbidity factors, and other CVD diseases, and whether they are aware of hypoglycemia and individual patient considerations also. Yes, when it comes to glycemic target, it can be stringent versus less stringent. It is obvious that lowering blood glucose reduces the risk of microvascular as well as macrovascular complications. However, overly stringent glucose lowering invariably increases the risk of hypoglycemia, and that will increase the risk of cardiovascular disease as well as the mortality. Therefore, particularly in vulnerable population, elderly, frail, limited life expectancy with lot of comorbidities, you have to loosen the glycemic target. Yeah. So what are the other targets? In a patient with type 2 diabetes who is uncomplicated, LDL target is less than 100. Blood pressure target is less than 130 by 80. In a patient of age less than 65 age group. And body weight, if patient is overweight, 5 to 10% weight loss is indicated. Yes. These are my take-home messages. When it comes to diagnosis, 2 abnormal test results or in the presence of classic symptoms of hyperglycemia, 1 result will confirm the diagnosis. Initial therapy, metformin is the preferred initial pharmacological agent in combination with comprehensive lifestyle modification. Add-on therapy, the choice of medication added to metformin is based on the clinical characteristic of the patient and their preference. And goals should be individualized, always based on duration of diabetes, age, life expectancy, comorbid conditions, cardiovascular disease, and other complications like risk of hypoglycemia. Thank you.